What are some things that maximize the opportunity for a couple to have a child?
That's a great question. So the first thing I tell people is just try to be your healthiest self. So, what I say to my patients is anything that you don't think would be good to put into your body while you're pregnant is probably the same thing you should try to minimize even before pregnancy or just generally in life. So, you know, once someone's actively looking into pregnancy, they do get more serious about looking at the source of their food, looking at the source of their animal products, looking at the storage containers. And you're probably wondering, well, why is that? Well, we happen to know, unfortunately, in a lot of our diets, we have additives. The truth is, our diets in the United States in particular, so for example, let's use Europe as the EU as an example. In the European Union, they have a lot of regulations that are very strict about what can be put in your food, what kind of plastics can be used to store or package foods, etc. We don't have the same regulations in this country. So what that means is there are actually a lot of additives and ingredients that are added to food, added to animal feed, animal stock, etc., that really shouldn't be in our food. And when they get into our body, they disrupt our hormonal system. So they're known as endocrine disruptors. Many of these things also aren't eliminated very cleanly from our body, so they actually just accumulate over time. So we happen to know, for example, that if you're eating animal products that came from animals that were fed hormones or antibiotics, those things, when they're in your system, can actually have an impact on your own biology, your own hormonal signaling, whether it be for mood, for inflammation, for reproduction. So we talk about eating organically as much as possible, hormone-free, antibiotic-free, pesticide-free. I'm a huge proponent of people growing as much of their food as they can, right? I recognize that there are limitations to that, but if you can't grow your food, then really try to eat as local as possible when possible. So again, you know where your food is coming from and you have an opportunity to interrogate the source of the food to know if it's really hormone-free, antibiotic-free, pesticide-free. When it comes to storage of food or heating up food, I tell people, use glass or ceramic for storing your food and for heating up foods in microwaves. We know that every time you microwave something in plastic, some of those ingredients can leach into food over time and build up over time. Certainly, if you microwave in plastic today and that's the only thing for the year, it's not enough, but it's more the accumulated
Right.
impact of these things over years and really decades of our lives. Staying hydrated, and then more importantly, working out. So I encourage that people work out, those 30 minutes 3 to 5 times a week, plus incorporating some resistance training, whether it be doing push-ups, using exercise bands, or just lifting weights 2 to 3 times a week.
So the biggest thing that you're saying is simple diet, simple exercise.
Yes.
I think every physician that I've had to talk about their specialty as it relates to mental health, whatever it is that they have going on, it relates back to diet and exercise and paying attention to the food that's going into your body. Oh, excuse me. And sleep also.
And sleep. Yes. No, I think, and that's what I really hope people will take away, because I've seen so many people, even during COVID, say, well, I wish doctors will emphasize nutrition and health. And I say, actually, we do. That's the basic tenet, right? We want everyone to take care of their bodies. We want you to eat healthy. We want you to read labels, right? Don't just buy things because there's a kitschy commercial or, somebody says, oh, this will taste good. Read the label. I use bread as an example. If you were to ever bake bread at home, at most you're putting 5 ingredients usually. Yet, if you went to the store to buy bread, most bread, when you start reading the label, you're seeing 10 plus ingredients. You're seeing labels, names of things that for sure don't exist in nature. That's a sign that maybe that's not the bread for you.
Yeah, I think one of the struggles, and I've discussed this also with other colleagues, is that we tell people to diet and exercise. The exercise is a little easier. You can walk, you can run, but diet is so complicated to discuss because I don't think dietitians agree on what's a great diet or what's healthy.
Yeah. Well, that's the thing. eating right. And then diet has cultural implications.
Oh, yes.
Diet, so what I may tell my patient from Southern India in terms of healthy diet based on what we eat in the United States may not match anything that they eat in their home. And so, one of the big things I'm a proponent for is when you're talking to people about nutrition, you have to meet them where they are. You can't tell them, oh, you have to do this way because this is how we do it. You have to actually say, okay, let me learn how you do it, and then let's see what we can change if you're looking for meaningful, lasting change. And I see it so often where patients fall off the wagon. They do the fad diet, but it's not sustainable. One, because you can't starve your body for too long. There's one analogy that I like, which is athletes don't diet, they train and eat nutritious food. And if you should treat your body the same way an athlete treats their body, which is you're eating for fuel, you're eating for the love of it, you're eating for the love of body, but you're not eating to deprive your body of key nutrients. And that's where we need to go, is you meet people where they are and you make sure what they're eating, once you meet them where they are, they're eating things that can be balanced and colorful and really getting all the food groups.
What I think is fantastic is patients, they trust MDs, they come to us, but I don't think and I've discussed this also with other colleagues, the fact that we don't get a lot of nutritional training in med school. So for the casual listener to this podcast, if you go to an MD and your MD says, watch your diet, and don't be afraid to go to a dietitian and ask some other questions as you would your doctor. Go to a dietitian. Go to a trainer.
I encourage any MD out there, even if you were trained in nutrition, it's really hard to have time.
Right. Yeah.
To spend all that time. And so unless you have a truly concierge practice where you can do that, it's going to be hard. So I recommend any MD, any physician assistant, any NP, if you're out there and you have your patients and you want to serve them well, you should be looking through your community to find dietitians, registered dietitians, meet with them. So like when I started here in Las Vegas, my first 2 months, I spent just reaching out to the community. I literally Googled LinkedIn as many dietitians as I could find who were registered dietitians. I sent them all emails from me to them, introducing myself, telling them how I like to work with dietitians, and setting up meetings so we can meet first so I can see if they understand the issues my patients struggle with, but also to see if they have similar ethos and philosophy to me, which is to meet the patient where they are, not just force them to do what you tell them to do, because we're looking for meaningful long-term change. And I recommend that anyone who moves to any community, that's what you do. Because, I might be coming out of Yale with all of my amazing ideas, but I come to Las Vegas and maybe people in Las Vegas must eat a certain thing because that's the core to their diet. If I don't work with a local dietitian who understands these needs, we're not going to make any meaningful headway with our patient. And yet I see that happen a lot. I see a lot of doctors coming out of their fancy programs and then they move to communities. And instead of learning what makes the community tick, they just start saying, well, you need to do what I learned at my block place of learning. That's how you eat healthy. If you're not doing that, then you can never be healthy. And we got to change from that mindset.
Yeah, the last few things I'll say, because you mentioned culture earlier, I can't tell you how many jokes I catch because I stopped putting so much salt on my food.
Right?
You have to make changes. But, that it doesn't taste as good, but I'm trying to actually make positive changes, and my friends just constantly make fun of me not putting as much. It's a cultural thing that affects you.
No, it's cultural. I mean, I remember when my mom's a twin, and when her twin brother's wife started cooking with less salt and stuff, the solution of the family was to have her cook her own food. And they kept cooking.
You do what you want to do. If you want to change your diet, you go right ahead. But us, we're going to do what we do.
Yeah, no, it's very funny because even my uncle, who usually doesn't cook, if he's having guests over, you'll hear him say, but I'll do the cooking, because he doesn't want her cooking her bland food, as he calls it. But it is culture. It just, but it's important. We have to be culturally sensitive. And if we're not taking that into account when we're talking to people about healthy lifestyle, healthy diet, healthy appearance, because in some cultures, one appearance is more healthy to them than the other. And so, again, that's where you have to meet them where they are and then slowly start working back to the space that is healthy if you really don't think what's happening for them right now is healthy.
All right. And last thing, because we got to get back to infertility. We're talking about it, but we're talking about but it's so important to what you're doing. It's like this is the biggest change that you mentioned for someone struggling with infertility.
Mhm.
There are episodes, folks, because access to healthy food is a problem too. There's an episode number 8 about food deserts you can listen to. And I also just dropped an episode today. It's number 20 and 21 with Austin Perlmutter, where we talk about what it takes to make long-lasting changes. So I just want to make people aware that those are some episodes that you might want to listen to that will pair with what we just discussed with diet. So getting back on the topic of infertility, when you make the determination that ultimately this is just not going to happen, they're just not going to be able to have a child, what then are their options for starting a family?
So the question becomes, what's the reason for not being able to have a child? So if it's, oh, they're out of eggs, then we could talk about egg donation if they're open to that. If it is that the uterus cannot carry a baby, we talk about surrogacy for carrying the baby. If it turns out none of that is available, then we talk about fostering versus adoption. We even have embryo adoption. So that would be where someone else who created embryos, maybe they're done building out their families and they still have embryos left over. There are many families who willingly adopt or donate their embryos to someone else who's struggling to conceive. And so embryo donation is an option, but it's not a very available option right now because only so many people are offering to donate their embryos. But other than that, then we start talking about adoption itself. Now, adoption itself in the United States is pricey. It's very expensive. And so you're looking upwards of $50,000 spent to adopt, particularly if someone's looking to adopt a baby. We know in the United States, adopting babies are truly premium in the sense that it's hard to find that many people adopting out babies. So the wait period is long. So for some people, it's too long a wait. We also have amazingly good reunification plans, even in adoption cases. So we all know in most states, it's anywhere between 30 to up to 90 days that the parents or parent who put the child up for adoption has to come back.
So you can wait 30 or 90 days and then the parent just says, oh, you know what?
Yeah.
Wow.
Mhm.
Okay.
And so because of that, certainly we also have patients who end up coming to a fertility clinic after an adoption has fallen through or after a series of adoptions have fallen through. Because even if there's somebody who's pregnant who says, yes, I want to give my baby up for adoption, etc. Once the baby's born, things change, dynamics change, and they might change their mind or their family may step up to the plate and say, hey, we're going to help you. You can keep your child, sort of thing. And then, like I said, 30 to 90 days for them to change their mind. So one of the things that I talk with families about is looking into fostering, right? You can start with the fostering process. With most states, you can sign up. The city is going to assess you, assess your home for stability. And if you qualify, then you become a foster parent. And so that's one way. And then after a certain amount of time of fostering, many times you then have the opportunity to adopt the children if they're not able to be reunified with their birth family. And so that's one way that people go about it. For some people, it's hard to get that closure though. Closure is hard.
Right.
And closure takes time. And that's where we really want to make sure they're supported. So it's really not just up to me. At that point, I'm making sure they have a counselor. Usually we have these things called fertility coaches, fertility doulas. So we're making sure these people are involved, getting them in with a psychologist, psychiatrist. Definitely, if you are someone looking into embryo adoption, egg donation, depending on the type of egg donation. Definitely, so for surrogacy, we involve a psychologist, right? So they have to be assessed by a psychologist. The psychologist actually has to clear them before we can move forward with the plan. Because, for example, surrogacy is interesting, right? If somebody's carrying a baby for someone, not only do we have to make sure the person who plans to carry the baby, the gestational carrier, is mentally and psychologically prepared for what's about to happen, which is they're going to carry a baby, birth a baby, and then give it up.
Yeah, yeah.
Right? So we have to prepare for that. But also, we have to prepare the intended parents, because usually the carrier is carrying their biological child. But while that child is growing in that person's uterus, it is that person's body, and they make decisions about that pregnancy. It's not the intended parents. They cannot decide what this person does with their body, when they go into labor, whether they deliver or not. And so we really make sure psychologists are involved to really explain the nuances of those relationships and the expectations and the autonomy of the pregnant woman's body as she's carrying a baby for you. Even though you're paying, maybe you're compensating her for that service, it's still her body. And until the baby is born and outside of her body, she makes the decisions.
In your experience, do you find that getting a therapist sooner rather than later would be recommended?
Oh, yeah.
Okay, I'm just taking a guess there about that, but I would imagine so. Like waiting until after maybe you have to deliver the news that this isn't something that's going to work out.
Yeah.
It would be better to have it beforehand.
It's super important to get them on board. The sooner the better. As you know, though, it's hard to convince people to get a psychologist involved. So, I have a number of ways that I approach it. Definitely, that's part of why I spend time in that first visit, really getting to understand the underlying health conditions, if there are any underlying histories of, say, an anxiety disorder, panic disorder, depression, psychosis, anything. So I can start saying, in this process, you really can find yourself going through some emotional highs and lows. It will be really important for us to start plugging you in with someone now, so you have that 360-degree support that you will need. And it's important to frame it that way. Not only that, with a lot of our treatments, we have also the highs and lows of hormones. And with those highs and lows of hormones can also come just tremendous sense of inadequacy and people not feeling like they're doing well, even if they're working. They feel like they're failing the relationship. They feel like they're being judged, even when people aren't judging them necessarily. So I try to do it really early. There's also a grieving process involved, particularly in this case, where if nothing worked and we have to talk about it. So it's really important to plug them in, because one, they're grieving the loss of their fertility, and we don't really talk about it as that, but it is a grief, right? The thought of, even if someone never really knew they wanted children, but finding out that now the options aren't there,
it changes things.
And so it's important to get that support in place to ensure that they are as surrounded with supportive language, not "I told you so," "well, you should have done this 10 years ago." Because, sometimes our families, our friends, although they mean well, they end up saying words that can really feel like a knife going through your system.
Yeah, as I mentioned earlier, being 32 now, I pretty much don't even bring it up, just because
it's always they're coming at you.
Okay, so advice for, and I would say for the ages of 35 and above, because I think that's when you mentioned 70%. No, 70% was at year 30, I think you said.
Yep. 97 by 40. So definitely at 35, people should be looking into it. Absolutely. What I say, and certainly it's part of my advocacy, even when I reach out to the OBGYN, is at 30, when you're doing that physical examination, what we call that annual examination, we should be asking our patients, again, it's not that you're judging, but the relationship of the GYN in particular and their patients is usually close enough that you can say, can I ask you, do you have any future plans for fertility? And if your patient says no, then you get to say, have you ever considered freezing your eggs in case you change your mind? And that's all you leave it at, right? You don't have to pressure them. It's just planting the seed. But as the OB-GYN, as part of your workup, also draw that hormone I spoke about, AMH, the one being made by the ovaries, to get a sense of what's going on in your patient's ovaries. right? Because if a patient has underlying things like endometriosis, etc., looking at them, you can never tell what's going on in their ovaries. And so you want to check just to give them a sense of where they are. I certainly had patients where that AMH came back low, which for us is anything under 1.5. If you're 30 or older and your number is under 1.5, you should be talking to a fertility specialist because your egg numbers are on the lower side. And so I've had a number of patients who come in simply because that test was done. There are now even direct to consumer testing that you can literally at home, you can just order the test. You don't even have to see an OB-GYN. And there are companies that will send you the test to your house. You do your own finger prick, send it back to that company in San Francisco, and you're getting your results. So certainly with all that in mind, I don't recommend the DTC without the supervision of a doctor, because again, if you're someone who has somewhat of a compulsive underlying disorder, or someone with a history of depression or self-harm, getting a test result like that without a physician who can explain what the result means and explain what your options are, that can actually lead to a very tumultuous sequence of events.
Right.
And so I recommend actually talking with the OBGYN, and I recommend OBGYNs initiate the conversation if the patient hasn't. Because again, we're usually talking about it. We're usually asking people about their sex life. We're usually asking about risk for infections. We're usually checking to see fibroids and stuff. At the very least, just check to see egg number. And so that's 30. And then I recommend every couple years, you just broach the topic again so that the patient is reminded. Because I'll tell you this, for a lot of the patients I see right now who are in their late 30s and 40s, no one ever brought it up to them, but they all say, I wish someone had.
Right, right. Okay. Well, I have three more questions. And I'm going to ask you to pull out your expertise in virology and your OB. You're an REI now, but you're also an OB-GYN too.
I am.
All right. So there's this thing called COVID-19 going on. You're aware of that? Yes.
I might have heard about it.
So for people that are pregnant or even thinking about becoming pregnant, the COVID-19 vaccine, do you have any thoughts about that? About the vaccine and being pregnant or about to become pregnant?
Yes, I recommend the vaccine, specifically the mRNA. So the Pfizer vaccine and the Moderna vaccine for patients who are planning pregnancy, and definitely for those who are pregnant. The vaccines are safe. The technology has actually been around for a long time. So, I know for a lot of people, their consternation is surrounding the fact that COVID only came around in late 2019. How can we have a vaccine so soon? But the mRNA technology has actually been around for well over 10 years. It has been studied in a number of different contexts, whether it be cancer, for Ebola vaccine, for flu vaccine. So we have data on the mRNA vaccines and we know they're safe. We know that COVID-19 disease, if you were to get COVID-19 while pregnant, the impact of COVID-19 on your pregnancy includes includes miscarriage. Miscarriages happen. We see an increased trend for stillbirths, meaning your baby being born not alive. We see increases of preterm delivery, preterm birth. And we also see, sadly, we're seeing higher rates of really bad outcomes in mom, including heart attack. We're not seeing high rates of death. So I don't want to scare anyone who's pregnant that if they got COVID-19, they will die. But what we're seeing is they get very sick. They spend long times, especially if they have underlying blood pressure issues, underlying diabetes, underlying weight issues, and are also pregnant and got COVID-19. They have higher complication rates, like I said, preterm loss, premature delivery, miscarriage, or mom herself up to 6 times more likely to have a heart attack, which is actually really striking because we don't usually think of heart attack in young reproductive age women.
Right. Yeah. So that's
I recommend those.
So that was another added to the list of reasons why I wanted to have you on the show to use that PhD. And lastly, the vaccine with breast milk. Is there any concern with that either?
Well, actually, I recommend getting the vaccine. Now, here's the reason why I also recommend the vaccine in pregnancy is because your immune system, as it boosts, not only would you have T cells, which are the special part of your immune system that fight off infection, but you're going to be able to make antibodies that serve two big roles. So the first is antibodies cross the placenta, and now they're in baby's bloodstream so they can protect baby after baby's born. Because here's the thing, right? For the first 6 months or so of a baby's life, they're not really making their own antibodies. So they're relying on mom's antibodies that crossed the placenta before they were born. And then, if mom's breastfeeding or pumping milk, she also has antibodies that come out through the breast milk that can also protect the baby. And that's really important because, for example, we now know that if someone is infected with COVID and we test their breast milk, we actually can find viral RNA in the breast milk. We can even find antibodies in the breast milk, which means breast milk might actually be passing infection to baby too. So if we can help you protect, why not have that protection rather than infection for your baby?
All right, let's go another one again. Another reason why you have on a virologist.
Yes. And it's why I recommend, it's why before someone gets pregnant, we test to see if they have antibodies to measles, to mumps, to chicken pox, hepatitis, HIV. It's because we know all of these viruses can have some really bad outcomes for a pregnancy, for the baby. And so we check because if we can boost mom's immune system by giving her booster shots, those help her baby. It's the same premise for the COVID-19 vaccine.
Okay. So second to last question. You mentioned that you thought about being a pathologist early on in your career. I, for a very brief time, thought about being an OB-GYN. Very brief. And I'm going to tell you why. I actually loved my OB-GYN rotation. Mm-hmm. And you actually...
What's not to like?
Oh, well, hey, okay. For people that cannot see her, she's laughing right now. We're both laughing because the OB-GYN rotation is one of the more demanding rotations in medical school. Not everyone walks away saying I had a great time, but I did. I had a great time. And what I realized is I liked my team. I thought they were pretty respectful, intelligent. We all worked together. There were three guys, three ladies. It was fantastic. I'm bringing that up because when I was on my rotation, I did not notice things that the statistics are telling me in terms of how women are treated when they're pregnant, particularly women of color. Okay. Yes. There is a statistic out there that, I fully believe. I understand that what the statistic is saying, that African-American women are 3 times as likely, I believe, to pass away during childbirth when compared to their Caucasian counterparts. Mm-hmm. My question for you, anecdotally speaking, because we have the stats. Yeah. I didn't see, because I was a med student, it was maybe 6 weeks time that I was on the rotation. And from my perspective, I didn't see a whole lot. And I don't even know if I would know what to look for. But coming from an OB-GYN, I'd like to hear from an OB-GYN, not some person writing an article for CNN or Washington Post. How do you feel that your profession or the people of your profession are approaching patient care of women in general?
Yeah. Well, I always say it's a multi-layered answer for a multi-layered problem.
Yes.
And so, yes, do we have cases where Black women of color have not been treated equitably and equally? Yes, hands down. But we also have data that says that patients who are treated for and cared for by people who look like them, those stats don't hold up. 2, even in cases where the treating physicians are white or non-people of color, it depends on their level of training, their level of exposure to what we have, which are systemic inequities, right? And just to give a sense, when we think of OBGYN care in America, the inequities are dating right back to the very start of the field of OBGYN. They go back to Dr. Sims and his experimentation on Black women without using anesthetic and all this stuff. And he wrote things that have now been hard baked into our textbooks, you know? So, for example, he wrote articles that said Black women don't feel pain. So to this day, we see where Black women, Hispanic women, and this was part of our maintenance of certification for 2020, for example, meaning the American Board of OB-GYN put out these articles to make sure all OB-GYNs in America are aware of this data, which is we have study after study that show we're less likely as a field in many places to prescribe Black and brown women pain medicine following C-section, even when we're prescribing it. So it's not just the death numbers, but there are a number of other disparities that we have to be aware of so that we can take away the biases. And many of the biases, we're not aware of them because they're actually hard baked into the field. They're hard baked into the textbooks, which is for well over 100 years, the textbooks said Black and brown women didn't feel pain the same way. And so that meant we prescribed for pain differently. It also meant that if a patient complained of pain, complained of discomfort, the field probably looked at it differently. Now, there's a lot of work meant to close the gap. We're doing better, but we still have a long ways to go. But I would tell you, I agree in the sense that it's not across the board. And I think that's what we need to do better at communicating. Because what we've seen instead, unfortunately, is we're now seeing a lot of Black and brown women opting not to deliver in a hospital, even when they have lots of complications, even if they have diabetes, even if they have a larger baby that's going to have birth complications. But they've heard these statistics and now they think it's every doctor, every hospital,
right.
I'm not safe, I'm 3 times likely to die. And so then they're putting themselves in even more compromised position. So we have to do better at communicating and getting out there to talk about where the communication errors are. And then at the same time, we have to do better in our institutions to highlight the disparities, which is not just training doctors. We have to talk to the midwives because, again, a lot of textbooks, even the midwifery textbooks, are informed by what the thought leaders in OB-GYN in the beginning of the field and the specialty wrote. And so we're definitely having to rewrite textbooks. We're spending time having to retrain people. A big part is also helping people identify implicit biases, which is how do you respond if a person of color tells you they're in pain? Do you hear that and assess them objectively, or do you hear that and filter it with a biased filter that leads you to ignore or dismiss their complaint? And we know it's not just a function of, oh, if you're wealthy, you'll do better, because we've seen what happened with Serena Williams. We saw what happened with Beyonce. So we know we have to do a little bit better when it comes to a lot of things. But we also know that the only way to make the change is to have the conversation.
Pointing it out, acknowledging that it exists and not just dismissing it. Right.
Correct. You know, like now we're saying 3 times more likely. 50 years ago, it was probably 6 times more likely.
Yeah, this is another one of those tough times where we say things are better, but there's a long way to go before long way to go before we reach the point where we say, all right, we're good.
It is. You know, there was a really amazing paper that came out last year, because you also see that statistic when you look at infant mortality, Black and brown infant mortality. And for example, there's a lovely study out of one hospital in Florida that showed, and then one out of Michigan, so it's 2, that showed that the rate of Black and brown kids dying was brought right down to equal with non-Hispanic, non-Black kids when the doctors taking care of them, the pediatricians, looked like them and lived in the communities they came from.
Right.
And that's just amazing in terms of what that means, because it proves that representation matters. It proves that community immersion, because here's the truth, right? If you and I live in the same community, we go to the same church, etc., we go to the same store, we're in the same social groups. If I come to you, I'm in your clinic and I'm complaining, like it or not, you know me. You're more likely to believe me. You're more likely to know if I say certain things from my social group won't work out. You're more likely to understand verbally, but even the nonverbal cues I'm giving,
Right.
because we come from the same group and we hang out together. Whereas if we live on two separate sides of towns, we don't actually interact. We don't know how the other one lives. The doctor's probably less likely to identify with you and capture some of those nonverbal cues as well, or recognize when you need more help because they know the circumstance. And so that's what we need to work on, and making sure that, we're not going to expect everyone to live in the same neighborhood as their patients, but we need more representation or more immersion so you understand.
Okay. Well, yeah, I want to thank you for speaking on that. It's really what I feel is a very hot button issue
It
that
is.
I
It
want to
is.
make sure that I give a voice to people that are actually in the field and watching this from a day to day, on a day to day basis, and not just researching it for 2 weeks or a month and then writing a story about it. I mean, you're in the
Yes.
field.
We
Um,
are. And I really feel like that's the thing. It's not so balanced. Sometimes the stories are written in a very sensational way,
yeah.
and they're written sometimes to elicit the most emotion, which we all need to be upset over the fact that we have that statistic at all. But we do need to ask, well, what's the cause? Because it's not just, oh, a doctor who is flagrantly racist led to something happening. It's actually institution set up. It's the fact that, a pulse oximeter, which is infrared, was designed to measure oxygen levels by reading through skin. But we know that infrared doesn't work very well with dark skin. And so a patient might be complaining of not being able to breathe, but you're going to look at the pulse ox and it's going to tell you that oxygen levels are high. But we need to learn, oh, there's some bias baked into the technology. So if my patient is saying they're struggling to breathe, I need to act on that, not just tell them, well, no, you're fine. Your numbers look good.
Yeah. Yeah. These stories don't always have to be sensationalized for people to pay attention to them. If you give people just the facts
Give them the
and
facts, the whole facts.
yeah, that can be effective too. And I completely agree with you. I'm going to move on because I'm going to start talking about my dislike for certain media outlets. We're going to move on. All right. So my last question for you, where do you see yourself and your practice going in the future?
Oh my gosh, we have so many amazing things coming on board. So we just added a couple new staff members. We're at the point where it's time to bring in another doctor. So
Wow.
the practice is growing. I also do international work. And so, having been born in the Caribbean, I have a virtual clinic there, but we've been working on expanding that and even putting a brick and mortar footprint. Um, so that's growing. And then just continuing to do amazing things and meet amazing people.
Well, Dr. Cindy Duke, I want to thank you so much for stopping by. I think you did a fantastic job. I think we just did, all right, we're about at an hour, 30 minutes
I
just
know, I
about
saw
the
that.
show. Thank you
Are you
so
going to do
much.
it as one, or are you going to break it up?
I'll probably break it up when it gets to longer than about an hour or so. I tend to break it up into halves.
Mhm.
Um, yeah, it depends after I look at everything, but
Yeah.
you did a fantastic job. Thank you so much.
Thank you. Thank you very much. This was great. I enjoyed it.
So how do people find you? What's your Instagram handle?
Yes. So you can find me across all social media as Dr. Cindy M. Duke. So Dr. Cindy M. Duke, one word. Same handle. You name the social media, I'm there with the same handle.
Okay, well
LinkedIn,
branded.
Tumblr, Twitter, yeah. Just one name, the same everywhere.
That's good branding, folks. Good branding. And
But make
you're
it easy.
what'd you say?
I said make it easy for them to find me.
And your clinic is the Nevada Fertility Institute.
Correct. So we are Nevada Fertility Institute. We've been here in Las Vegas. This is our fourth year in Las Vegas, because it was launched in, actually technically the fifth year, because I launched it in November 2016, but we're in a permanent home as of March 2017.
Fantastic. Okay, well, I'll put any other information where people can find you in the description. Again,
Yes.
thank you so much for stopping by. It was a fantastic discussion. I hope this is going to be beneficial for any gender, any
Yes.
age. Take care. Thank you so much.
My pleasure, and happy to be here. I'll be back anytime.
Bye-bye.
Thank you. Bye.